Just about ready to start?
I'm ready. I'll demask.
Okay, so welcome to Grand Round. Today, as you can see, Frailty Placing Muscles center stage. Dr. Amanda Hill, well-known geriatrician, executive and leader in the Department of Medicine, who's almost retired, is now giving great. So, welcome, Amanda.
Thank you very much. So I was meant to be having knee surgery yesterday, but I delayed my knee surgery to do these rounds. So I hope it makes it worth it. And I've made myself, having knee surgery last year really brought this issue to the forefront for me. So we'll refer to that as we go. So just to talk about frailty, a syndrome that is marked by loss of function, strength, and physiologic reserve, with increased vulnerability to morbidity and mortality. It's due to age-related declines in physiologic reserve across neuromuscular, metabolic, and immune systems. So if you look at this picture, you do not need to know their ages. You do not need to see their faces to know their age or to guess approximately their age. So we see frailty, it's very evident to us, but it seems kind of hard to unravel it. What are the concrete elements of it? It seems like this big blur. And I would guess the woman in the pink hat is not her granddaughter, it's her daughter, right? Just by the posture, the whole muscle strength. And if you look at what is defining it, to me, a lot of what's defining that image is the muscle strength. So the objectives is, first of all, that for you to be convinced that frailty is in fact a robust clinical construct, sarcopenia as a core element of that, the pathophysiology of sarcopenia, the interface with acute illness, and strategies. My goals, in fact, are for you to throw away your stethoscope when you do rounds and take around a full two-wheeled walker. Because I don't care if the first and second heart sound are still there after 3 weeks of hospitalization, and nobody else does. But I really do care whether you can measure sitting balance, whether you can get someone to stand next to the bed with their walker. So that is my goal, that you will throw away your stethoscope and instead invest in a two-wheeled walker. Goals. So this is a busy slide, but it actually is very informative. So up to date, thank heavens for up to date, although it doesn't do well in sarcopenia. Within the sort of molecular level of frailty, we know that as we age, there's increasing oxidative stress on cells. Oxidative stress causes apoptosis, decreases function. Telomere shortening seems to be an age-related effect on DNA, which affects replication, cell replication, DNA damage, and cell senescence, which is kind of a little vague. There's definitely gene variation. Some people age better than others. There's inflammatory diseases and comorbidities will make a big difference in how frail you get. And I actually firmly believe that environment plays a huge role. So if you place somebody in a stress environment, lower socioeconomic, marginalized communities, frailty happens sooner than if you're living in a privileged environment. How that happens in physiologic systems, there's increased inflammation, and there's neuroendocrine dysregulation. Now, I know these seem vague. I wish I had a pointer here. Oh, here we go. No, it won't let me do it. Here it is. So this sounds all like blah, 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 but it actually is super important when we come to discuss sarcopenia. So the increased CRP and IL-6 are increasing inflammation, and we talk it inflammaging. So there's a chronic low-grade inflammatory state that's happening in older adults that is playing a devastating effect on muscle and other tissues. Similarly, the androgenic hormones here, anabolic hormones, are impacting on muscle and body strength. They don't mention glucose here, which is effectively an anabolic hormone and can also affect muscle growth. And we get decreased insulin resistance. So that's important as well. How does that play out in physiology? I'm going to focus on sarcopenia because I think it's so obvious. It's staring us in the face. We don't label it. We don't address it. We don't own it. And I want us to change that. Impaired immune function, cognition, we've started to really pay attention, and impaired glucose metabolism. And this is how we see the patient. This is the Freed frailty scale. They're slower, they're weaker, they've got weight loss, involuntary weight loss, low activity and fatigue. And there's that lady, somewhat scooped. You can see she's weaker. She hasn't got the core strength to maintain herself in an upright posture. She's weaker, she's slower. She's probably lost weight. She's very fatigued with minimal exertion. So it's not a vague thing. It's a pretty concrete thing that we're seeing. And how can we give it that? I want to convince you it's measurable. I'm going to convince you it predicts outcomes and has distinct features. So this is my first slide to convince you. So the surgical literature was the most convincing that it predicts outcomes. So there are a number of these studies. And this is a guy called Macri. He used that Freed index that we talked about. And when he looked at 594 patients undergoing major surgery, looking just at the not frail and the frail, not frail 19%, frail 45.5%. Disposition to skilled nursing facility, which is rehab, 2.942, length of stay, 4.2, 7.7. So using just that score, he was able to predict those outcomes. We could take this and inform our practice when we undergo colonoscopy, when they undergo any kind of intervention. The risk of negative outcomes is much higher, and it's easy to define that risk. Similarly, this guy's Robinson, he's been a guru of this, and he uses a whole different score. What does he use? The CAT score, which is ADLs, timed up and go, comorbidities, anemia, cognition, albumin, and a fall. And again, the non-frail, any complication, 21%, the frail, 58%. So it's very powerful as a tool to predict. We have a man in Canada called Afalalo from Montreal. He does the same thing. If you look at post-TAVI, somebody who's frail, the one-year mortality is 65%. So now when you've got a patient coming in with aortic stenosis, and, you know, should we send them for all these CATs and goodness knows what, we know that the one-year mortality, if they're frail, is 65%. That's with a TAVI. And what's the mortality without a TAVI? So it really informs us to say, what are we doing? You know, let's make sure we do the right care. Having said that, the non-frail, fabulous. So it's not age that determines it, it's their frailty. So it's a measurable, and it predicts outcomes, and it's not hard to measure. But for me, what's been underlying the core of it, and I think why it's always been, let's go to what tool. So you'll hear a lot of talking about how you should measure frailty. It seems like it doesn't matter what tool you use, as long as you measure it. But core to most of the tools is a functional and mobility and muscle kind of based element. And those seem to be the most predictive, which is why I've come to sort of focus a little bit on sarcopenia as a very core element of frailty. And really, as I say, go back to our first picture, it was very evident when somebody's sarcopenic. So it's an age-associated loss of skeletal muscle mass and function. From the fourth decade of life, you start to lose skeletal mass, and it decreases in a linear fashion. By age 80, you've got about 50% of the muscle mass you have when you're age 40. Now, when people exercise, they can maintain some of that muscle mass, and we'll go to that later, but they're two competing. The medical literature appears to say exercise does not impact on sarcopenia. The exercise physiology says exercise does impact on sarcopenia. I believe it does. But there is a process that's going on, whether you exercise or not, that's causing muscles to become weaker, become less, and become very vulnerable. This is really the best group that's defined this muscle. We've got pre-sarcopenia, when there's low muscle mass, but you're still doing just fine. And that's probably maybe me. Low muscle mass plus low muscle strength or low physical performance. And then severe sarcopenia, where there's low muscle mass, low strength, and low physical performance. And that's really our guys. That's geriatrics. These are our guys, and they're out there in huge numbers, and the numbers are increasing, and we've got to recognize it. So this is an MRI of a 25-year-old. So I said, this is the medical student, and this is the attending. So next time the attending's making you feel bad, just think of his muscle mass. Just think, wow. So here's the 25-year-old, and you see it's a nice mixed fibers. There's nice mosaic, nice arrangement. As you get older, there's more adipose in the muscles, so that affects both muscle volume, but also muscle metabolism. There are 40% fewer fibers in this man. There's atrophy of the type 2 fibers, so you're seeing losing out on these small other type 1 fibers. What also happens is that the motor units in young people, you've got a lot of nerves feeding your motor units. With age, there are less nerves feeding more muscle fibers. So there are less motor units, which makes the whole thing less flexible and reflex. So when you need to do something fast with reflexes, a young person's got all those neurons firing to the muscle units, very responsive, and it's less responsive with age. So just a thing. But that's a pretty dramatic slide, and this is a healthy 75-year-old. So when we look at the causes of muscle atrophy with sarcopenia, it's very similar to frailty, and it probably is the same mechanism, but we'll go through it a little bit. So the muscle composition changes. There's redistribution of muscle fibers, adiposity infiltration, as we saw in the picture. Intracellular changes are super important. So there's a shift towards breaking down of protein. Proteins are not as robust. There's increased susceptibility to oxidative stress, and there's impaired oxidative function. And I want you to remember that when we talk about acute care, muscles in acute care. Decreased number of motor units. The satellite cells are what repair. So when you tear a muscle, the satellite cells are the ones that come in and do the work. And the satellite cells are less. And there's systemic effects. So there's decreased anabolic hormone levels. So there's less muscle getting anabolic hormones. And there's also glucose resistance, which is super important. Interestingly, inactivity actually generates free radicals. So think about that, about your patients in hospital. Inactivity generates free radicals, worsens muscle function, malnutrition, and comorbidities. And there we get the perfect storm of decreased muscle strength, muscle quality, and physical performance. Interestingly, muscle bulk does not determine muscle strength or muscle performance. So those wiry older ladies who are still going strong out there with tiny muscles, and this big ex-rugby player who's using a walker, his muscles are huge, but they're not working as well. So the muscle size, it does not impact on the performance. So looking at somebody just sort of, oh, she's super skinny, she must be very frail, is not adequate, because that there's not a good correlation. I think also what I want to convince people that muscles are not just for movement. They have a huge metabolic role. So I want you to start to embrace the muscles as an organ system that is dispersed with multiple functions. Yes, we all know it moves things, but it also has a massive metabolic role. So 40 to 50% of body mass. It has 20 to 30% of oxygen consumption, but super importantly, handles 75 to 95% of all insulin-mediated glucose disposal. And we're very well aware of the long-term effects of sedentary activity and the metabolic syndrome and how that's been driven by immobility and obesity. You can see muscles have a huge metabolic role. And when there's a loss of muscle mass, there is a metabolic effect. And it really makes me think of frailty in acute care when people are put to bed, or at ICU when they're not moving and they're not using their muscles. Have we any idea what that metabolic effect has over 2-3 weeks of immobility? I don't think we've even begun to explore that. Then we start to understand why it's so hard to get people up and moving afterwards. So the prevalence of sarcopenia, 15% in healthy older adults, up to 76% of acutely hospitalized older patients, and 69% post-acute. These numbers are super vague. I have to tell you that the measurement and the actual definition of sarcopenia is not great. We're only starting to get that. So you're going to find wide ranges of numbers, but I don't think it takes a genius to walk onto the board and see there's a lot of people who are suffering severe muscle weakness. So the consequences, I'm just, partly these are kind of self-evident, and they kind of, the motherhood says it's not good to be weak. Yeah, we get that. But what's interesting is the things that are not related to motor function, which may tie into the metabolic function. So there's no question that cognition can be improved with exercise, depression, and then the others are sort of related to muscle function per se. So sarcopenia and critical illness is what I wanted to bring to you. So this lady her muscles have got a creatinine equivalent of 365 and an EF of 30% and severe COPD. Her muscles are just hanging in by a thread. She is extremely vulnerable. We're going to put her into bed and we're going to have catastrophic muscle loss and mobility failure. So we've got to see this and recognize it and take it seriously. This is all of our business when we see somebody like this, right? So you've got to learn to recognize and realize this is a potentially catastrophic outcome for this patient. You'll see Dr. Spencer's talk. What do people fear most? Nursing home. More than death. They fear nursing home. What's our job? So we have to embrace the muscles as not just the physiotherapists and the geriatric team. She's medically stable. Absolutely. Sodium's good. Oxygen's fine. She's medically stable. She can't walk to the bathroom, but call geriatrics. No, you haven't done your job. Her muscles are her system. Muscles are our job. They're not someone else's job. So it's a common sequelae of critical illness. And they're very similar mechanisms. When we talked about the effects of aging on muscle, in acute care, there's very similar effects. So we'll go through that. And just think of muscles as vulnerable. We talk about a vulnerable brain now. We've done that work to get Delirium on the front page, and the vulnerable brain is super important. We know that they're at risk for delirium. Vulnerable muscles, something you need to see. So when you get an inflammatory response, so the mechanisms underlying sarcopenia are amplified in critical illness. So the acute inflammatory crisis results in profound muscle wasting by TNF-alpha, which is what I pointed out to, the CRP and the IL, all these cytokines are upregulated and they cause damage to muscle. They also, this stress and the inflammatory response causes mitochondrial dysfunction, which we already have in sarcopenic muscles. And interestingly, this idea that keeping people in bed causes accumulation of free radicals, more damage to muscles. Interestingly, surgical stress also is associated with mitochondrial dysfunction. And I had a knee surgery last year. I cannot believe how weak I was after that surgery. Within days, my muscles had shrunk, and I could not straighten my leg. It was extraordinary. And this kind of precipitated some of my fascination with what happens to muscles in acute. So it's really not a minor thing. Very important, malnutrition. So in early starvation, gluconeogenesis from hepatic stores, but after 24 to 48 hours, you're starting to break down muscles to produce those amino acids needed for gluconeogenesis. And unfortunately, the type 2 muscles, which are your power standing up muscles, are preferentially subjected to proteolysis. So, when we keep people NPO, when we keep them NPO to be assessed by the speech pathologist on Monday, and they can't swallow Friday, Saturday, Sunday, this is not okay. These muscles are on life support. We need to pay attention to them. They are our job. So we've got to start changing the culture where we place these as a very important piece of our assessment. So the interventions, again, a lot of them motherhood statements that, nutritional support, avoid unnecessary starvation, try and get adequate protein intake. Medications. You got a lady who looks like that, and you put her on a atorvastatin 80 milligrams a day? Was she in any of the trials? Have we any evidence we're going to do any good? Have we got a strong suspicion we may do harm? Yes. So if you don't have evidence that you're going to do good and you may do harm, I think we need to know where that balance lies. So when you've got a frail older person, look at her muscles and say, am I going to give her a beta blocker? Am I going to give her all the neuroleptics are hard on muscles? All the statins are hard on muscles. Pravastatin. Okay, you've got 80. She wasn't in the trial for 80. Go 10. Go 40, but don't go 80. The other thing about medications is postural blood pressure. It's a major limiting factor for people mobilizing. Time and again, we get called geriatrics, failure to mobilize, failure to thrive, whatever. We go, and sure enough, the blood pressure drops to 60 when they're standing. And it's like, really? You did your job? This is not good enough. We've got to be paying attention to people's ability to mobilize. So these are all, as I say, motherhood statements. But I think what's really required is a culture shift, where doctors don't disown muscles, when we don't say call the physiotherapist, when you don't actually ever see a patient walk, but you're still listening to their chest when their sats are fine and their respiratory rate's fine, and if you have crackles, you're not going to do anything because it's probably atelectasis anyway. Like, why are we spending all that time on this old-fashioned traditional stuff when we're actually in a new era of medicine where the most important thing for these patients is to move? But you still listen. I listen. When I was a medical student, I listened first because sometimes people got endocarditis rapidly. It was a different time, but even then it was stupid. It's so stupid. So let's use that time and energy in a way that's actually going to help our patients. So major culture shift. So next time you arrive on rounds with a walker, you can just tell them, Dr. Hill told you to do it. And it's not that hard to mobilize patients. I've walked, honestly, every patient I've ever seen, I've got up and walked. I've had one person go syncopal and faint on me. So once you learn how to do it, it's not that hard. Sometimes if we have a number we measure, we're much more likely to pay attention. So measuring muscle, this is DEXA scan. You can do a CT, and some of the oncology groups do CT L2, L3, and look at muscle mass in that area, paraspinal muscles and abdominal muscles, and use that as a a marker and a way of monitoring, MRI, but really cool, Dr. Manili and Dr. Madden are doing ultrasound, so they can actually look at muscle mass, and they also look at the nature of the muscle. If there's a lot of echogenicity, it suggests there's fat in the muscle, so that they can look at muscle quality. It doesn't measure function. Maybe if we did that when somebody came into ICU and we monitored them, or came in, or we started a statin, we started with a baseline, and then we monitored, if we had a number, then we would be more able to embrace that, because we're very numbers oriented as internal medicine. But with geriatricians, we're happy with uncertainty. Like, how far can they walk and how fast can they walk? And that's good enough for me. I don't need a number. But that's important. The other thing about the traditional neurologic exam, another thing drives me crazy. You see, this is my last grand round, so I can offend everybody. So in terms of the neuro exam, there is nothing in the neurologic exam that measures core strength. There's nothing in the neurologic exam, traditional neuro, that measures core strength. I mean, you go to trainers, all of you are personal trainers, yoga class, Pilates. It's all about core strength. I don't care whether you can do this or this. I don't care if you can lift your foot at the bed. I care if you can walk. So the best way for measuring core strength is getting sitting balance, standing with the walker, and then seeing whether people can walk. Really, unipedal stance is a great measure for core strength. Do they tip over? Can they hold their... So core strength is not measured in the traditional neurologic exam. And I can tell you from years of experience, too many years, that the neurologic exam in bed is a very poor predictor of somebody's ability to walk. Unless you're going spot the lesion. If you're playing spot the lesion, that's great. But I'm not that interested in the lesion. I want to know if they can walk. So you need to get somebody to walk if you're doing a neurologic exam. So that's important. Can it be prevented? Well, we kind of discussed that, and I want to leave time for Martha. I haven't got any time slot here. Can anybody tell me? Oh, there's no... Unknown caller. Sorry, what's the time?
You're good, Amanda. It's only 12:20. You're good. You got lots of time.
Okay, I'm whipping through because I don't want to take up your time.
Don't worry about it. Got lots of time.
Okay, so there's, you know, physical activity. As I said, they say it prevents frailty, but not sarcopenia. That's a bit of a... So that was a big meta-analysis was done. If you look at the literature from the exercise physiologists, they say that weight-bearing exercises twice a week for 3 months can reverse 2 years of sarcopenia or something. Some numbers like that, but definitely there's two different lenses on this, as they frequently are when you come to exercise versus traditional medical thing. But I don't think for those of us who do this work, or those of us who face sarcopenia and go to exercise programs, doubt that you can gain muscle by exercises, and it's good functional muscle. So exercise programs are super important, and super important to encourage your patients, if you're going to be in preventive clinics or in midlife, to start encouraging weight-bearing resistance training, get a personal trainer, get a kinesiologist, start working on it now, because your muscles by the age 60 are already probably down 15% from age 40. And the only way to prevent this, and then you get an acute event like my surgery, and it was like, oh my God, this is dramatic. So you want to be ready for that acute event when it happens. So I went through very fast because I was wanting to make sure there was time. It's not so complicated. Frailty is not so complicated. And for me, increasingly, it talks about the vulnerability of other organ systems, and we're really good at pre-op doing an assessment of respiratory vulnerability, cardiac, renal, but we're not that good. But we've been working on that. Particularly, Martha's been driving a lot of this pre-op assessment of the vulnerability related to frailty. The element of frailty that I think is easy for us to embrace and for internists to understand is the sarcopenia, is the muscles. So my plea is embrace the muscle system as an organ system that's just as vulnerable as the kidneys and everything else. It's a huge impact on quality of life, and we can make a difference. We can make a difference. So again, to go frailty is measurable. And basically I've said that. So I don't know whether I'm going to achieve my goal of you picking up a walk and going on rounds, but I do think that when presenting a patient who's elderly, you know, you should be at least aware of their mobility daily. You know, that should be at least, my thing is, you know, your issues list. Yeah, their sodium's fine and their white count's down, and that's all great. That's easy stuff. What's their walking distance? Should be me, number one on your problem list. Because if you ask the patient, they don't really care about their white count. They only care about their white count insofar as it gets them walking. So start to really embrace that as part of your clinical practice, because you're entering an era of internal medicine where Everyone's going to be frail and elderly. And if you need to shift from the single problem-oriented, why can't pneumonia is better, now the patient's well framework, it just doesn't work like that anymore. Pneumonia is one piece of this, and it's complex, and you need to have the holistic picture to look at a patient's wellness, not the single disease system model. That's gone. That days are gone. Barring some patients, but for the most part, it's going to shift more and more to complexity, and where a single disease system module, it just doesn't work anymore. And the muscles are great. It's fun. It's fun getting people walking. So that's what I have to say. And I think we'll probably let Martha have her talk, and then I'm happy to discuss questions unless there's something very pressing right now you want to say. Good. Thank you.
Great, Amanda, if you can take your slides down.
I'm going to press none. Yeah, none. Yeah.
Okay, perfect. And I will share my screen. Okay. Can you guys see my slides? They should. Oh, there they are. I can see them up in the room. So hi, I'm sorry I can't be with you today. If you missed my spiel earlier, I'm here in Kelowna, and looking forward to getting back with you guys on Monday when I start CTU. Hopefully, if the highways cooperate, I'll find a way to get there either way. I'm Martha Spencer. I'm one of the geriatricians at St. Paul's. I also do some CTU, so we'll meet you guys there next week. So we're going to shift gears a little bit, and I think, Amanda has given us a really nice introduction to frailty and sarcopenia. And what I want to do is give you guys a practical approach to how we can use that concept of frailty and sarcopenia in our everyday work. And I'm specifically going to focus this case on critical care, so older adults who are getting really sick. And obviously you guys are doing CTU, so you guys embrace acute illness. And I think it's very important to know what it means in terms of our older patients and what outcomes frail older adults may have. So before I start, if everyone can just mute their microphones, I think there's a little bit of shuffling going on there in the background. All right, so this is Mr. V. He's an 82-year-old man. He lives at home alone. He presented to the hospital last night with fast atrial fibrillation, and despite multiple doses of IV metoprolol in the emergency room, he's still going pretty fast. So he's admitted to 5B on the cardiology unit on telemetry, and unfortunately, overnight, he becomes unwell. So he develops chest pain, shortness of breath. His troponin goes up to 500. He's clearly in heart failure. His ECG shows some ST depression. And later that night, the resident on call gets called again because he becomes hypotensive and they can't wake him up. He's really, really drowsy. And so everyone rushes to the chart to try to figure out what his code status is. But he was admitted overnight and he was a bit confused in the context of his rapid atrial fibrillation, and no one was able to get a hold of family. So for now, he is full code. And so the social worker, is scrambling, trying to find a family member who you might be able to call. But we need to decide, when we get a hold of this family member, what are we going to ask her? And I think this really goes back to Amanda's talk and the importance of frailty on outcomes in older adults. So these may seem like simple things, but as I'm going to show you, these really do go into the decision-making about older adults in acute illness. So what is their pre-morbid level of function? Can they do their ADLs, their IDLs? What is their exercise tolerance? Do they have sarcopenia? Have they had mobility issues or falls? Obviously, pre-morbid cognition is really important when we think about the vulnerable brain and delirium risk. Their nutritional status, obviously their comorbidities factor in, and very importantly, what are their goals and values around critical care? Because it sounds like this patient may be headed that way, and we need to really have a discussion with the TSDM about that. So we finally get a hold of a daughter, and from a social perspective, us geriatricians are always interested in knowing people's backgrounds because it often becomes relevant when discussing goals and values. So this is just a gentleman from Germany who immigrated to Canada in the 1950s. He owned a butcher shop, but unfortunately had a stroke around 4 years ago and had to sell it. So he retired at the ripe old age of 78. His daughters describe him as fiercely independent. He is widowed and has 2 daughters who are very supportive and live locally. Since his stroke, has been more functionally disabled, so needs 3 times a day home supports to help with his ADLs, and has had 20 pounds of weight loss. And as Dr. Hill said, when we're losing weight, it really is part of that frailty sarcopenia syndrome, which is certainly something to take into account in this patient. His daughters support all of his IADLs. He mobilizes with a cane, but lately hasn't left the house because he's just too tired, and he's had 3 falls in the last 6 months. And unfortunately, over the last little while, he's had progressive short-term memory and functional deficits since his stroke. So Mr. V actually has a relatively short list of medical problems compared to a lot of the people that we see in geriatrics, but most notably, he has cerebrovascular disease with a stroke and left-sided weakness, hypertension, BPH. He's had a cataract removed and is an ex-smoker. So using this information, how are we going to use what we've learned about Mr. V to counsel his family about his particular outcomes should he need to go to the ICU, because it is looking that way at this point. And so, this really wouldn't be a geriatric talk if I didn't at least bring up the clinical frailty scale once. And this is something that you guys are hopefully familiar with. This is Ken Rockwood. He's a geriatrician in Dalhousie, who's really a leader around the world in frailty. And this is the clinical frailty score that he developed as part of the Canadian Study for Health and Aging back in 2005. Some of the wording was updated more recently in 2020. And this is really based on people's activity level. And I think sarcopenia really fits into this, as Dr. Hill was saying, their active disease and symptom burden, and most notably their activities of daily living and instrumental activities of daily living, so their function. And if we think about Mr. V is a 6 on the clinical frailty scale. So if we read what 6 is, he's living with moderate frailty. He needs help with all outside activities, with keeping house. He needs help with bathing, and does need some assistance with dressing. So certainly fits in this kind of 6 category. So does frailty, and I would argue also sarcopenia, I guess, predict outcomes in critically ill older adults? And this is a bit of a leading question because yes, it does. And I'm going to show you some evidence to support that. So this is a study done actually in Ottawa, a retrospective study looking at older adults with sepsis in the ICU. And they divided these patients into frail and non-frail based on the clinical frailty score using a cutoff of 5. And so Mr. V is a 6, so he would be in the frail category. 5 and above is mildly, moderately frail. And so if you look at these numbers, basically those who are frail have about 2 times the chance of having in-hospital mortality, having a longer length of stay, needing long-term care admission after discharge, and needing readmission after hospital. So without looking at any other factors and just looking at people's frailty, we can predict people's outcomes in the ICU to a large extent. And when we look at the older, so those over the age of 80, this was a multi-center ICU study done in Europe. It was over 20 countries in Europe, over 300 ICUs. And you'll see here on the x-axis, we have the clinical frailty scale. So from 1 to 9, as I've just showed you, and mortality. And when you look at the blue line there, that is acute admissions. And so if you look at mortality for acute admissions, according to the clinical frailty score, your mortality definitely increases as you are more frail. And if we look where Mr. V would be, he would have about a 50% mortality if he were to go to the ICU, according to this study. And keep that number in mind, because that's going to come up later. That seems to be consistent across a number of different studies. This VIP2 study looked at a number of different things in ICU patients over the age of 80. So things like frailty, cognition, activities of daily living, and comorbidities. And what this study found again was that the clinical frailty score alone is an independent risk for 1 month prognosis after ICU admission. And even adding other geriatric syndromes or the SOFA score, for example, other scores did not improve the model. And so these authors basically conclude that one score, the clinical frailty score, is feasible in circumstances of rapidly processing of decision-making to admit or refuse an old patient in ICU. And I don't quite love the wording in terms of refusing, because I think it still has to come down to informed decision-making with the TSDM. But I think the point is made that irrespective of other factors, if we know how frail a patient is, it makes it much easier to give a prognosis about what their post-ICU course might look like. And one of the things they say in this paper, which I like, is predicting the future, we must look at the past. And I think as geriatricians, we really embrace the social history and the functional history, because at the end of the day, it is very, very relevant in terms of outcomes for our patients. And, the data I've showed you so far pertains mostly to death. And as Amanda said earlier, most of our patients, actually death is not the worst outcome in their mind. The worst outcome in many older patients' minds is actually disability, mobility failure, functional decline to the point that they would require nursing home or being a burden on their family. So I think it's also important to look at other outcomes that we might want to share with patients and families. And so this study looks particularly at mobility disability or mobility failure. And I think, again, this really goes back to the sarcopenia, the influence of sarcopenia. And so this is a study done in Japan that actually looked at ICU patients 18 and over and factors that affected their mobility. And what this study found, again, was that clinical frailty score was actually the only influencer of mobility disability. So not age, not the SOFA score, not vasopressin use, but the clinical frailty score alone did predict mobility disability or mobility loss in the months that followed ICU stay. And delirium obviously is something that we're very aware of in our acute stay in hospital. And this is a study called the DELI study, so the delirium and ICU study. And this is part of some of their baseline data. And what they looked at was frailty on admission, risk of delirium in the ICU, and risk of death. And certainly those were frail, had more delirium, which is not surprising. Those who had delirium had more death. And if we were frail and had delirium, our outcomes were very poor. So to the point where in this study, 1 in 3 frail patients with acute delirium in the ICU did not survive until hospital discharge. So using delirium as a significant prognosticator, and I think this is also true for a lot of our patients who are ill on the ward, using delirium as a prognosticating factor, especially when it's severe and prolonged. And so this study used Fried's phenotypical model, which Dr. Hill went over earlier in terms of self-reported exhaustion, grip strength, decreased exercise tolerance. And you'll see here again that frail patients had about 50% chance of surviving after the ICU. So even using a different measure of frailty, we're still getting kind of the same numbers. And importantly, the number of disabilities goes up after ICU, the frailer the patient. And in this study, again, a very important outcome in our patients was that frailty was certainly associated with discharge to nursing home after the ICU, which is not a tolerable risk for a lot of our older adults. So just to conclude, something that comes up a lot, especially with residents that I work with on CTU and on geriatrics is, when I go to the emergency room overnight and I'm talking to an older patient about, their code status in the hospital, what do I tell them? Like, what do I tell an 85-year-old about their outcomes? And so I thought I'd just review a little bit of the data there, just to round out this talk and give you guys some more practical tips that you guys can use on the ward. So this was a study done in the UK looking at in-hospital cardiac arrest. And again, they divided patients by clinical frailty score. So 1 to 5 and frail 6 to 9. So that would be our patient, Mr. V. So your chance of having unsuccessful CPR is about 70% in the frail group versus about 40% in the non-frail group. And survival to discharge for frail people is very low. So only one person who was frail in this trial actually survived a hospital discharge after their CPR. And we do know, although we like to focus on frailty instead of age, we do know that irrespective of frailty, age does have some effect on CPR survival. So this was a large study in Austria that looked at CPR out of hospital cardiac arrest and CPR and survival, and divided patients by age quartile. So age less than 65, 65 to 74, 75 to 84, and above 85. And when you look at percent of return of spontaneous circulation, in your younger patients, about 45%, your older patients, about 25%, and 30-day survival going down to, about 9% in those 75 to 84, and about 4% in those over the age of 85. And the CPC score is a measure of neurological recovery. And you can see that those that are above 75 have very low chance of having good neurological recovery if they do survive CPR. And it is important to note that across all of these age quartiles, frailty is still associated with increased mortality. So these are all averages. So if you have a frailer 85-year-old, their percent of surviving CPR is going to be even less than this, and maybe a more robust 85-year-old, maybe a little bit better. So frailty still factors in as well as age here. And so in summary, when we're thinking about outcomes in our older adults, it's not enough to just go to the past medical history, look at their age and say, your chances aren't great. It really is important to consider frailty, because the studies I've shown you hopefully have shown that, frailty is a very big factor, irrespective of age, irrespective of comorbidities. It really is a lot about frailty in our older patients because of the heterogeneous nature of older adults. And so it really is important to ask about function and frailty, understanding goals and values, and also knowing about the outcomes. And I hope I've shown you a little bit of that data today. And then therefore kind of really getting to the point of informed shared decision-making, where you're going to talk to the patient if they're able to engage, and a TSDM about what is your recommendation going forward about their chances in the ICU or chances with CPR. And so if we go back to Mr. V for a second, he is living with moderate frailty. So he's clinical frailty scale of 6. When we talk to his family a little bit more, he does value length of life, but after his stroke has made it quite clear that he's not willing to sacrifice quality of life. So being able to return home, for example, for more time. And when we look at the data, his chances of survival to discharge post-ICU are about 50%, according to the trials I've showed you. He certainly has chances of high risk of mobility failure, delirium, and a high risk of discharge to a nursing home, which he says is not going to be acceptable to him. And his chance of surviving CPR is very low. And he's very unlikely to have neurological recovery if he does. And so I think in an informed shared decision-making way, probably recommending that this patient maybe shouldn't go to the ICU knowing his goals or values, or at the very least, CPR would likely be a futile thing to do in this poor gentleman. And so, obviously measuring frailty takes time and takes effort. And, if you do have a patient who you're really worried is going to go downhill, is very sick, you've got out the walker, like Dr. Hill told you, and they haven't been able to stand up and they're clearly sarcopenic and frail. Geriatrics is always willing to help with those patients to engage in these discussions early around frailty and prognosis. So please do call us. And obviously our palliative care colleagues are also experts at this if you need our help. And so with that, we'd love to have some questions and discussion about anything that Dr. Hill or I have talked about. Thanks so much for your time and coming today.
Martha and Amanda, it's Barry. I'd like to just bring a couple of points. One, you both mentioned that age is not part of frailty scoring. Is that correct?
Yes.
So you're using a pretty sophisticated, if you will, assessment of one population, and you're using the geriatric population as your example. But we don't use that same scoring system on many other populations, and then look at outcomes. So in fact, if I were a geriatrician, I would be promoting the health of these people with trying to support a lot of different things. You're pointing out that they may end up in different situations, but just by the information and by the appearance, the act of resuscitation and the promotion of other health goals, including rehab, is less aggressive sometimes, as you see in the elderly population. So I guess my issue is we don't use scoring systems like you're using the frailty scoring system to decision make even with a patient. So think about those psychotic patients that come in with drug overdoses or post-surgical patients, a variety of things. It seems to me that this population that you're referring to suffers maybe more than the other populations by using these systems. I'd like your comments.
So you're saying this tends to bias our care to provide less care? Is that what you're suggesting,
Yes.
Barry?
Yeah.
I was, I was just, before you spoke, I was just going to point out, and I did try and emphasize that in the slides. If you look at that population who are not frail, age is not a defining feature. They do incredibly well. So older adults who don't have frailty do as well as younger adults, have almost equal outcomes. So that's a really important piece. I agree, Barry, we don't want to do less care. So, I mean, I guess for me, what it is right care, because sometimes doing things has worse outcomes in the longer term for the patient than doing less. Sometimes it is important to sit on our hands. And to find that right sweet spot is really hard to do in this patient population, because doing a colonoscopy on a frail 90-year-old can have catastrophic outcomes. On the other hand, are you giving less care by not looking for their cancer? So I think, we're always dancing this dance as to how much we should do, and we don't want to do less. But I think providing people with the real outcomes in terms of their likely functional outcomes and what the real hospital course will look like, not just their heart and kidneys, but also their cognition and their mobility and their risk of functional decline, gives them the information to make a very informed decision. So I do these pre-op assessments. We both do them. And, should I have a TAVI? Well, we look at the data. They're frail. The likelihood of functional decline is this. The likelihood of delirium is this. These are your likely outcomes. Do you still want a TAVI? No. Good. Okay, that's fine. But if you're robust, go for it. So I think it is a balance.
And I think, Barry, there is also a lot of ageism that we see as well, right? And so there are 90-year-olds who should go for surgeries. In the peri-op clinic, I would say the majority of patients we see, the surgeon has already kind of looked at them and said, okay, they're old, I'm not really sure. And the majority of them are actually non-frail and, are good candidates for surgery or are good candidates for treatment. And so I think if you look at the flip side of it, looking at somebody's frailty is actually a better marker than just saying, well, the patient's 90, so we shouldn't really do anything, because that's not fair either, right? So I think there are a lot of non-frail older adults, and I think in our work we get very biased because we're seeing sick older people all the time, but there is this subset of non-frail older adults that we should be more aggressive with their care in terms of risk factor modifications or surgeries or whatever the case may be. So I think there's two sides of the coin there as well.
Yeah, and I'm sorry, to belabor it, I agree with you. There are two sides, and I'm just saying that you've used a tool to look at a population, which happens to be the geriatric population. We don't use similar tools in other populations to see outcomes and whether it's worth going to support and what support would be necessary and what the outcomes are. So, and to that extent, you're using a tool that sort of that's why my point of disadvantaging a population based on their age.
So younger people aren't held to the same scrutiny of whether they're suitable for. I agree with you. I think we've been asked to become more involved in other frail populations. The renal patients, we see quite a lot of them, and they're younger and certainly have a huge burden of frailty, hemodialysis and pre-transplant patients. They also, interestingly, people who've had long-standing HIV, we've had a few of them. We increasingly see them referred to our clinic for assessment of frailty, because we know that with HIV, because of we don't know exactly the mechanism, but there is premature frailty in people with long-standing HIV, 28, 30 years on antiretrovirals and doing fine, but they have earlier frailty, both cognition and mobility. So we see that group. So we are starting to see other populations who are younger, who are clearly frail, and starting to apply these tools to them as well. But I hear what you're saying. It is an interesting thing that the younger population doesn't get the same scrutiny as to their frailty as the older population. But I think, honestly, older people would generally thank you for that scrutiny, because they don't really want to spend, 4 weeks in, on the ACE ward trying to recover and then go to nursing home and spend, many people, for them, that's the worst outcome. So they actually welcome that honesty to say, look, these are the potential outcomes. They'll say to me, oh, I don't care, I'll die on the table, I'm 90. And I say, I'm not worried about you dying on the table, I'm worried about you going to a nursing home. And it's like, nursing home? Absolutely not. So they welcome that ability to use that information.
Thank you.
But it is an excellent point. It's an excellent point. Any comments? Does anybody want to know where to buy a walker? Yes.
Sorry, Amanda, you're going to have to repeat the question because...
Sure, yeah. Oh my God. Such a good question. How do we actually implement a mobility assessment, particularly in the era of COVID? And I think that's a super challenge. I have to say that COVID has been catastrophic for many of our patients in terms of their mobility. People going to gyms, going for walks, going to the community center have stayed home, and we've seen dreadful outcomes. So I can't talk about all the COVID precautions, but I can tell you very simply, getting someone sitting up, swing their legs over the side of the bed, and just assess their sitting balance is going to tell you a ton about their core strength. Simply as that. If you have to peel them off the bed in order to slip the stethoscope behind their back, they have got no core strength. So the sitting balance will give you a ton. If they can't sit up, do not try and stand them. If they slap, but they can sit up straight, then if you're feeling so inclined, you get a walker and you ask them to stand. And you've got their standing strength, 1-2 steps. You've probably done enough. You can sit them down. You've identified core strength, you've identified quad strength, whole glutes, pelvic floor, pelvic muscle strength in terms of standing. You've done it. And you probably, much more effective than lifting one leg off the bed and one leg off the bed to see if they're strong. That's not going to tell you anything. So that just the sitting balance itself is huge. So I can't say, how much time you spend with a patient with COVID. That's too complicated. There's no good answers to COVID, right? But just that assessment will give you volumes of information.
And, I would say having been on 7B quite a lot, as a COVID doctor and also seeing people on 7B, I think it is a huge service if you have patients on 7B where there is unfortunately a bit of a less focus on rehab, less support for that that should be your physical exam maneuver someday, is just getting your patient out of bed, because they may not have had the opportunity to get out of bed in a really long time. And, not only does it prevent sarcopenia, but we know it prevents risk of delirium as well, to get people up and moving. And so patients on that ward, I have noticed, have been particularly susceptible. Through no fault of the ward, they do amazing work there. It's just their focus is elsewhere. And so getting patients out of bed on that ward and on all wards is important, as Amanda said.
Honestly, listening to their chest, and when the sats are fine and the respiratory rate's fine and you've got the vitals in the chart, if you're going to spend time, just sit them up at the edge of the bed. That's Gil, hello.
Hey, great talk.
Nice to see you.
Nice to see you too. Just a quick question. I was curious, let's say we have a patient that's like at the frailty score level 4, and we're discharging them home. What's the recommendation in terms of daily exercise? Is there any guidelines on that, what a target should be for a patient? Let's say 3, 4, 5, something like that.
Yeah, there's new data about that, Gil. It just came out, the Canadian guidelines. So it's 150 minute, like working up to 150 minutes of physical activity. And they've incorporated like light housekeeping, gardening. So incorporating not only, walking as part of that, like some type of light aerobic exercise as part of that, but even household chores, gardening, that kind of thing as part of physical activity. But the Canadian guidelines are currently working up to 150 minutes of some physical activity weekly. And I usually tell my patients, you might not be able to get to that right away, especially after the hospital, but even starting with 5 or 10-minute walk like every day and working your way up, and considering those light housekeeping things as added minutes, I think is a really nice bonus for patients to get closer to that goal.
Thanks.
Yeah,
That's great.
I agree. I think that's a gentle start, but I'm much more aggressive in terms of you've got to get your heart rate up and you've got to get a little sweat going if you want to build muscle. And so I strongly recommend for any of my community-based patients who are not super frail to get a personal trainer or a kinesiologist and engage in an active weight-bearing program at least 2 to 3 times a week, plus walking, if they want to build up muscle and stay strong. In a rehab, kind of gradual rehab post-hospital, that'll be one thing. But if you're going to actually get them strong, I think we really dismiss old adults when we put them in the chair and this is your exercises, sitting there, I'm doing exercises. We're not doing exercises. So you've got to do muscle resistance. You've got to treat them with respect that they want to build up muscle, they want to get fit, they want to get strong, and you got to push them. So I'm much more aggressive in terms of pushing people. You've got to sweat, you've got to get your heart rate up, barring massive comorbidities. And obviously that's context bound, not every patient. But as Barry said, we don't want to we want to give them that respect and that opportunity to get well and strong and fit and healthy, and set them as that as a goal, not to dismiss them with sitting in a chair exercises.
And Gil, I think putting in a plug for our elder care clinic, if you do have a patient who did get really deconditioned during the hospital, our physiotherapists have new group programs that I've seen them. They're not only sitting in the chair, they're doing a lot of work on balance and actually getting their heart rate up. They're doing really amazing group exercise classes. So especially for patients maybe who financially can't afford the personal trainer, the kinesiologist, you can always refer to our clinic for support there, especially if they're pretty deconditioned after hospital.
Thanks. Yeah, I think that that's a really maybe a reason why patients are so reluctant to go to long-term care, because they know that the rehab perhaps is not challenging enough. And I just wonder if that's something that we should think about to try to improve on an ongoing basis, because maybe that would make long-term care more attractive to some patients that don't have the support at home, but yet still want to optimize their physical conditioning.
So you're caught in a cycle. If you look at the features of frailty, exhaustion and fatigability are high factors. So for people who are very frail, it's almost impossible to break that cycle, because to exercise enough to build up muscle, they get too exhausted and they're too fatigued to do it. So they are already in the cycle. I'm talking about a reasonably robust, when you said critically frail, 1, 2. But once you're meeting the criteria, they're too exhausted and fatigued to engage in the exercise program. And you really have to acknowledge that and just kind of in a very palliative way be where they are. And where they are is not to build up muscle. But for people who can, I think you should.
We have a question from Dr. Tothill. Are group exercise classes going on these days and in person? Does anybody know that?
Oh, sorry, I just answered in the chat, but I'll So community centers are opening again. My patients are back swimming and back doing some of their exercise classes. And our physiotherapists have been doing small group classes through most of COVID outdoors, and are continuing to do those. So I think we are starting to see some improvements. So and at the hospital, they are too, Andrea. Yeah, so our ACE unit is doing group classes.
So we have follow-up clinics for medical follow-up for all of the disciplines. Is there any follow-up exercise or rehab component to everybody discharged that is frail?
I mean, the elder care clinic does follow up for patients but there's no structured or community physiotherapist referral but there's no absolute predictable that you are going to get it. It's only if it's referred. Can I make an important point, though, quickly before we end, is that with dementia comes apathy. So when you get a demented patient and you got to tell them you got to go exercise, and the family say he never does anything, sits on the couch all day, the apathy will make an exercise program impossible to implement. And it's extremely important to recognize that. So a strong feature of dementia is apathy. That is no fire. I don't feel like getting up. I just sit. And my brain doesn't say, I want to do this, I want to do that, I should. It just doesn't fire like that. So people just sit watching TV all day, totally contented. There were people who used to exercise, play squash, go to the gym, do this. Now they just sit. So then the family come along and say, Mom, get Dad up, take him to the gym. You can't. If it's not there, it's not there. So that's the other confounder we encounter when we try and encourage people to exercise. If there is dementia, there's likely apathy, and that's going to, again, cause a cycle of decreased physical activity and increasing frailty. It's very common. Demented people sit in the chair something like 9 hours a day. You know, they move extremely infrequently. It's frightening. Yeah. So it's all complicated.
Thank you both for the presentations and the stimulated questions that came, I guess, partly from myself, but I get from others in terms of how to deal with these populations. I really think it's helpful to hear this information, not only for this population, but I guess for all of the populations that come into hospital. So thank you. I'd like to announce what's on Grand Rounds next week, but I don't know. So you'll have to come and find out. Thanks, everybody.
Thanks, Barry.
Thanks, everyone.
Thanks, everyone. Thank you. Bye-bye.